Right, thank you very much. Sorry about the limping. I just pulled my leg muscles this morning. Right, I'm glad that Mark concluded his talk by talking about the outflow and the lack of cycle-destruction when you do MP3. So what I'm going to do is going to talk to you about a study that we're conducting in a moment. This is disclosure, acknowledgement, and now Sandra has also touched upon how this the MicroPulse laser may work. What is interesting is if you look at the UBM study from San Francisco showing that morphologically on UBM, there's hardly any changes at all post-MP3 treatment. This is from Sheng Lim in San Francisco. Now, so I want to share with you a video clip that I've taken of a patient having just had cataract surgery. We were going to do ECP, but I thought, well, you know what, I'll try MP3, but I put an endoscope in the eye to see what is going on with the ciliary epithelium. So this is the ciliary epithelium here, seeing here. Now, as you see, these are laser being applied at the moment. You see the slight indentation? So the laser being applied, and what you can see is nothing. There's no changes, there's no whitening of the ciliary epithelium, there's no popping of the ciliary epithelium. So when you're applying to the MP3 laser on the eye, there appears to be no changes at all to the ciliary epithelium. So question is, if it doesn't affect the ciliary epithelium, which we know that produce aqueous in the eye, how does it cause the drops in IOP? Now, this is the interesting study from Murray Johnston in Washington. So this is a cadaveric eye. When you apply the MP3 laser, as you apply, you can see the contractions of the ciliary muscles. Now, the question then you ask yourself is, if it's not affecting the ciliary epithelium, it's affecting the ciliary body, could it affect changes in the uvuscular pathway underneath that? These are the selections of publication for my group, for my lab regarding aqueous dynamic, if you want to learn about it. Essentially, we have technique in my lab to measure the aqueous flow rate using fluorophotometer, and we can measure the outflow facility using a tonography machine. So couple that with a Goldman equation, which I'm not going to bore you with, you can essentially calculate the effect of any kind of glaucoma treatment on the outflow, uvuscular outflow, trabecular outflow, and aqueous production, with some strict criteria has to be fulfilled. For example, patient mustn't have previous intraocular surgery, including cataract surgery or laser iridotomy. So once you fulfill those few criteria, this is a very viable way of measuring mechanism of action of any glaucoma treatment that you may have. So this is a very generous funding from Iridex. We were looking for 30 patients, and I must stress that all this work's been done by my research fellow and all my technicians who work on this project. We so far have recruited 25 patients, and 25 patients have washout. Now, this is important. What we're doing here is probably the only washout IOP pre and post MP3 treatment. So patients are only early or moderate primary open-angle glaucoma. None of those patients had advanced glaucoma. None of them have any previous incisional surgery in the eye. They were taking 1 to 4 drops. We invite them to be part of the study. We wash them up out of the medication, and after a month, they have a baseline measurement of the alpha facility. We were hoping that at 6 months, which we will do, there will be washout again of all their glaucoma medication if they're back on any, and then remeasure the aqueous production again, and alpha facility, and all the other parameters to see what's the exact mechanism of action of MicroPulse laser. Obviously, in order to do that, we have to measure the parameters we mentioned earlier, but for safety reason, we also measuring OCT, pupil diameter, specular and microscopy. We're looking at topography, the anterior segment OCT, refraction, biometry, UBM. We measure IOP by 4 techniques, eye care, pneumotonometer, and aura, and also we are measuring the accommodation. We just want to see absolutely any safety or any other anatomical physiological changes to the patient's eye after MP3 laser. I'm not going to bore you with that, except I've used a very standard treatment regime of 80 seconds using peribulbar, which is my preference because I don't have easy access to anesthetic in some of my lists. So this is the washout IOP. So post-washout, the average IOP is about overall of 24 patients, about 26, 27. And day one is about 16 to 17, 37% reduction. And 1 week is about 47% reduction. And 1 month, 28% reduction. Now bear in mind, all of these patients are not on glaucoma medication. The part of the reason we chose early glaucoma or moderate glaucoma is that we were hoping we can hold off treatment to look at the true effect of the laser rather than introducing medical treatment to completely bias and the result. So how about adverse event? Not a single case is CMO. Don't forget we're doing a pre-treatment macular scan and post-treatment macular scan. We're doing scan at every post-op visit. Only one patient had uveitis after more than 2 weeks, which is back on steroid treatment for another 2 weeks and settled down completely. 4 cases out of 24 require repeated, out of 20, repeated treatment, so about 20%. But that's fine. So essentially, the summary of my study so far is that it is early day, we haven't completed the study yet, but this is, however, the first washout MP3 study using ocular hypertension or early to moderate glaucoma. So far, we have excellent IOP result. Some patient needs to repeat treatment, but it has really important to stress in those eye who has good vision, no other previous intraocular surgery, and not advanced glaucoma is really safe. So far, anyway. And that's it. Thank you very much.